You're lying on a wooden table. It creaks beneath your weight every time you try to shift, but your arms are tied. So are your legs. Leather straps tightened so hard you can feel your pulse in your wrists. Your mouth is dry. Your skin is cold. The only thing warmer than the oil lamp above you is the sweat collecting in the small of your back. You're awake, and you will stay that way. The surgeon stands over you. He's not in white. He's in black or brown, something dull and heavy. No mask, no gloves, just rolled sleeves, stained apron, and a set of metal instruments beside him on a cloth. Not sterilized, just wiped. He doesn't ask if you're ready. Because readiness isn't part of this. A man stands at your left shoulder. His job is to hold your arm down, another at your right, one near your feet. They are strong, silent, and used to this. You wonder how many people they've watched scream. You wonder if they count. There's a saw on the tray, a hook, several knives, not all sharp. The surgeon clears his throat and looks at you once, and says the only thing anyone will say to you today. Try not to move. That's when the knife enters, not slowly. There's no time for gentle. The blade splits your skin and your body jolts, not just from the pain, but from the realization that this is real. You try to scream, but someone puts a leather strap in your mouth. You can still taste the last patient's fear on it. There's no anesthesia, no chloroform, no blessed numbness, only the sound of metal on flesh, the crack of bone. Your own muffled breathing as the blood pools under your back, and through it all, you remain conscious. Because that's how surgery worked in 1835, and if you survive the shock. If you survive the blood loss, the infection, the pain, they'll call it a success. They'll call it healing, but you'll never forget the moment before the first cut. When you realized what no one had told you clearly, you will feel everything, and you won't be able to move. Before anesthesia, surgery was not a calm clinical procedure. It was a race, a brutal, desperate calculation between time and death, and every second mattered, not to save the patient from pain, but to save them from dying of shock because of it. Operating rooms weren't clean. They weren't even called operating rooms. More often, they were wood-floored chambers or lecture halls, sometimes with sawdust scattered on the floor to soak up blood. Windows open, no ventilation. No masks, no gloves, just sweat, shouting, and steel. The tools were heavy, crude, often reused dozens of times, scalpels dulled with repetition, saws that cut through not just bone but clothing, flesh, skin, muscle, all in one motion. Hooks for holding open flesh, forceps to remove bullet fragments or bladder stones. Surgeons operated in aprons streaked with old stains. They didn't wash their hands, not because they were careless, but because no one yet understood germ theory. The dirt under their fingernails was never questioned. It was just part of the job. And the patients, they were wide awake, tied down to benches or chairs with leather straps. Sometimes held in place by multiple men, two at the arms, one at the legs, one at the head. Some patients bit down on cloth, others screamed until they passed out. Some never screamed at all because the shock of the first incision had already pulled them under. An amputation had to be fast. A good surgeon could remove a leg in under 3 minutes. The best could do it in under 2, not out of cruelty, out of necessity, because every moment spent cutting was a moment closer to death. Bleeding was controlled by heated irons pressed directly onto open vessels. Infection was a roll of the dice. Mortality rates hovered at 40, sometimes 60%. Some patients died not from the wound, but from the pain itself. There were no antibiotics, no antiseptic, no recovery wards, just straw beds, vinegar rinses, and prayers. If you survived, you were lucky. If you walked again, you were a miracle. And if you complained, you were ungrateful. Because pain back then wasn't just accepted, it was expected. It was proof that the procedure was real. And if you didn't scream, the surgeon assumed he'd done something wrong. In the world before anesthesia, the most valuable tool in a surgeon's arsenal wasn't compassion, it was speed. The longer a patient lay open, the closer they came to death, not just from blood loss, but from the sheer trauma of pain. Too long under the knife and their body would simply shut down, the heart would give out, breathing would stop, shock would take them before infection even had the chance. So the best surgeons learned to cut fast, not carefully, not delicately. Just fast, they were called speed surgeons. And they were heroes in medical halls filled with students and spectators. Their performances were legendary. One man would hold the arm, another the shoulder. The surgeon would step forward, blade in hand, and the clock would start. A few clean sweeps to slice through the flesh, a tug of bone, a flash of the saw, arteries clamped, seared with hot iron, bandages wrapped. All before the patient passed out or screamed themselves into silence. Robert Liston, the most famous British surgeon of his era, could amputate a leg in under 2 minutes, sometimes under 30 seconds. He was called the fastest knife in the West End, and yes, that was a compliment. One of his operations is still remembered not for its success, but for its casualty list. He reportedly amputated a man's leg so quickly, he also sliced off 2 of his assistant's fingers. The patient died of infection, so did the assistant. A third spectator fainted from the sight and later died of shock, 3 deaths. One surgery, 100% mortality, but Liston's fame didn't suffer, because most of his patients lived, relatively speaking, thanks to his speed. These were not quiet men. They worked in blood-streaked aprons, shouting orders, tossing tools across tables. They measured their worth in seconds and screams. Their hands were steady, but only when moving fast. Hesitation was the real killer. And yet the pain was never questioned. It was part of the process. If you couldn't bear it, you were weak. If you did, you were cured. There was no talk of trauma, no space for dignity, only the clock and the knife. Amputations were only the beginning. What came next were the operations that didn't just sever limbs, they went inside, and the patient was always awake. In the absence of anesthesia, surgeons still pressed forward with procedures that today would require full sedation, sterile instruments, teams of assistants, and weeks of recovery. Back then, you got a wooden table, a dirty blade, a few strong men to hold you down, and the hope that you didn't bleed to death before the infection set in. Let's start with bladder stone removal, a common procedure in the 1700s and 1800s. The pain of bladder stones was excruciating, and surgery was the only option. The patient, typically a man, would be positioned upright or on his back, legs bound, genitals exposed. No anesthesia, no numbing agent. A long, thick metal instrument would be inserted into the urethra, or a perineal incision made to access the bladder directly. The surgeon would search, by touch and by sound, for the stone. When located, they would attempt to extract it using forceps, sometimes breaking the stone apart while it was still inside. Some stones were the size of eggs. The screaming could last nearly an hour. Many men passed out from pain and blood loss mid-procedure, and if they lived, the chances of dying from infection in the following days remained brutally high. Then came tumor removals. Without anesthesia, removing a breast tumor, often from women with late-stage disease, was a calculated nightmare. The patient was seated upright, her arms tied, a cloth placed between her teeth. The surgeon would slice fast and deep, ignoring screams. There was no time to go slowly. Some tumors were so large they hung visibly from the body. Others were deep in the chest wall. There was no way to tell how far to cut, only that it had to be done. Many women vomited from pain. Some fainted and were operated on anyway. They called it courage. The women called it survival. In some cases, ovarian surgeries were attempted, including oophorectomies, removal of the ovaries, with no anesthesia and only a few assistants. The abdomen was cut open, the organ located and removed. The patient would scream or seize. Nurses would sometimes sit on the torso to prevent movement. These were called heroic operations. And if the woman died, it was recorded as unsuccessful but necessary. Even children weren't spared. There are documented cases of children undergoing trepanation, the drilling of holes into the skull to relieve pressure, while fully awake, held in place by assistants in straps, with nothing more than brandy or a damp cloth for comfort. Some survived, many did not. To modernize, these procedures read like horror. But in the 18th and 19th centuries, they were not fringe. They were mainstream medicine, and they weren't hidden. They were taught, demonstrated, applauded. Because the ability to cut a living body open, while it screamed, thrashed, or simply froze in terror, wasn't seen as cruelty. It was seen as mastery. In modern medicine, pain is a sign that something is wrong. In Victorian surgery, pain was a sign you were still alive. There were no anesthetics, not yet. Ether and chloroform wouldn't appear in operating rooms until the mid-19th century. Before that, the only indication that a patient hadn't passed out or died mid-surgery was the sound of their voice. More precisely, their screaming. Doctors listened for it, expected it, relied on it. If the patient moaned, groaned, thrashed, it meant the heart was still beating. If they went silent too soon, the surgeon moved faster. Not out of kindness, but out of fear that the body beneath them was already slipping into shock. In this world, screaming was vital data. Hospitals adapted to it. Operating rooms were often built away from the main halls, not for privacy, but to muffle the sounds. In teaching theaters, students watched surgeries like public performances. The louder the patient, the more impressive the case. They didn't always tie patients down with leather. Sometimes they used rope, sometimes they used people. Attendants or family members were asked to hold the patient's limbs during surgery. One for each arm, one for the legs, one near the head to press down the jaw, or in some cases, to clamp the mouth shut with bare hands so the patient wouldn't bite through their own tongue. In some records, mothers held their sons down, wives held their husbands. It wasn't called cruelty, it was called courage. Some surgeons advised patients to bite on wood or cloth, others didn't bother. They believed the pain was part of the cure, something to be endured like a penance. The greater the suffering, the more grateful the survivor would be, and if the patient didn't survive, well, at least they died awake, at least they had faced it. There are written accounts of patients begging not to be operated on again, of people who returned from surgery unable to speak, not because their vocal cords were damaged, but because something deeper had broken, not just flesh. Something that lives inside you and goes silent when it's betrayed, but still, the knives kept cutting, the screams kept coming, and no one tried to stop them, because in this era, pain wasn't something to avoid, it was evidence. Evidence that the surgeon had done his work, that the body had suffered, and that medicine somehow had been performed. In the 19th century, medicine didn't just pathologize the female body, it tried to control it, and when persuasion failed, the scalpel followed. Women were sent to doctors for being too nervous, too emotional, unmanageable. For grieving too long, for not wanting children, for wanting too many, for speaking up, for staying silent. No matter the symptom, the conclusion was often the same: there is something wrong inside her, and we must remove it. This was the golden age of so-called gynecological surgery, not guided by science but by suspicion and silence. One of the most notorious practices was the removal of ovaries, a procedure called oophorectomy. Doctors believed the ovaries were the root of hysteria, depression, menstrual irregularity, sexual desire, and defiance. So they cut them out, not metaphorically, literally. Without anesthesia, a woman was restrained and opened. Abdomen sliced, organs exposed, ovaries excised, no consent, no explanation. Some women were told afterward what had been done, others never were. The pain was unbearable. The recovery, if they survived, was long and brutal. But to the physicians of the time, these women were saved. Not from disease, from themselves. Sometimes the diagnosis was uterine insanity. Sometimes nymphomania. Sometimes just difficult temperament. The justification didn't matter. What mattered was that the woman was no longer a problem. It didn't end with the reproductive system. Breast removal was common, even when cancer wasn't confirmed. Some doctors saw the breast as a source of excessive femininity and sought to remove it to reduce temptation or grief or distraction. Others inserted vaginal devices to correct behavior. Women who expressed trauma were labeled hysterical. Those who resisted treatment were given clitoridectomies, the removal of the clitoris, again, often without consent, and when they protested, their words were discredited. Their memories doubted, their suffering reframed as mental disturbance. Because once your body was labeled defective, your voice no longer counted. They called it medicine, but it was punishment wrapped in the language of progress. And once it was done, there was no undoing it, no apology, no explanation, only silence and scars that never got written into textbooks. In the 19th century, pain wasn't just accepted in medicine, it was respected. Doctors didn't merely tolerate suffering, they believed it meant something, that it had value, that the more you endured, the more likely you were to be healed, or changed, or purified. It wasn't seen as cruelty. It was framed as moral necessity. There were entire lectures written about this. Medical journals praised the fortitude of the patient and the noble honesty of unmedicated incision. Surgical textbooks described pain not as a side effect, but as a measure of therapeutic integrity. To numb it would have been to cheat the process. They called it character building. They said it proved strength. They said it separated the weak from the worthy. Women were told to bear it as a test of virtue. Men were told to endure it in silence or risk being labeled cowards. Children were told the pain would make them grow stronger. All were told that pain was necessary because pain meant the treatment was working. In some religious communities, pain during surgery was even seen as spiritual. To suffer without screaming was to be closer to God. To bleed and survive was a form of resurrection. The surgeon was not just a technician, he was a moral authority. And if the patient couldn't endure it, that wasn't seen as a failure of medicine. It was seen as a failure of the patient. This mindset allowed atrocities to go unquestioned. If someone died from pain-induced shock, it was God's will. If someone refused treatment, they were ungrateful. If someone begged for mercy, they were hysterical. And worst of all, if someone survived but was never the same again, never quite spoke right, never trusted anyone, never stopped shaking, then that was simply the price of progress, because medicine at the time wasn't just about removing disease. It was about reshaping the person, their body, their behavior, their place in society. And pain, raw, loud, undeniable pain, was how the system knew it was working. The breakthrough came in 1846. At Massachusetts General Hospital, in a crowded surgical amphitheater, a dentist named William T.G. Morton administered ether to a patient before a tumor was removed from his neck. The man lay still, no screams, no struggle. The operation ended and the patient woke up, alive, silent, intact. It was a miracle, it was science. It was the end of pain, or at least it should have been. Word of ether spread quickly. Within a year, surgeons in London, Edinburgh, Paris were experimenting with it. Chloroform followed soon after, easier to administer, less flammable. By all accounts, these substances should have revolutionized surgery, but they didn't. Not immediately, not everywhere, because even as patients begged for relief, many doctors hesitated. Some outright refused. The resistance came from many corners. Some said it was dangerous, that it interfered with the natural rhythms of the body, that putting someone into unconsciousness was too risky. And yes, early on there were complications. Doses were inconsistent, inhalers were imprecise. A few patients died, not from the surgery, but from the cure. But that wasn't the real reason many resisted. The real reason was ideological. To many surgeons, pain was not an unfortunate side effect. It was proof of treatment, proof of virtue, proof of moral worth, they believed. If you couldn't face the knife awake, then you didn't deserve to be cured. In some religious circles, anesthesia was considered ungodly. Pain was part of divine punishment or divine purification. To remove it was to interfere with God's will. There were sermons against chloroform, pamphlets distributed claiming it weakened the soul. Even when Queen Victoria famously used chloroform during childbirth in 1853, breaking centuries of tradition, some clergymen publicly condemned her decision. Because childbirth too was supposed to hurt, hospitals debated whether to offer ether at all. Some made it optional, some charged extra. In poorer communities, it was simply unavailable. Pain relief became a luxury, not a standard. And so, for years after anesthesia became known, thousands still screamed on the table, not because they had to, but because someone else decided they should. Progress had arrived, but cruelty still had the final word. By the mid-19th century, hospitals had everything they needed to end surgical suffering: anesthesia, basic antiseptics, a growing understanding of germ theory. And yet the screams didn't stop overnight. They lingered for years. For decades, because knowledge is not the same as change. Knowing how to reduce pain doesn't mean you will. Knowing how to save a life doesn't mean you'll value it. We have records of men who died from post-operative shock. Their hearts stopped not from blood loss, but from the trauma of pain itself. Of women who never walked again after abdominal surgeries done without consent or anesthesia. Of children who were strapped down and drilled into because their seizures were misunderstood as madness. We have numbers, hundreds of thousands operated on between 1750 and 1850, tens of thousands who died from infection. Thousands more who survived but never recovered, not in body, not in memory, not in trust. What we don't have is account of how many lost something deeper, the belief that they were seen as human. Because when medicine becomes a performance, a race against time, a showcase of precision, a test of stoicism, the patient becomes a canvas, not a person, and that's what happened. For nearly a century, surgical success was defined by one thing: the skill of the surgeon, not the comfort of the patient, not the dignity of the experience, not even survival, just the act of removal. A tumor, a limb, a piece of the self. Pain was never the failure, compassion was, and the only reason that changed was because enough people finally asked a question no one had dared before. What if pain isn't proof of healing? What if pain is a sign that something about this system has always been wrong? They walked out with bandages, missing limbs, scarred torsos, wounds still weeping under layers of linen, but they were alive, and so the surgeons called it success. They had endured the knife, endured the heat of cauterization, the agony of conscious cutting, the screaming of their own bodies being dismantled, and they had not died. That in 1802 was enough. No one asked how they slept after. No one studied the way their hands shook, or how they flinched at the sight of metal, or how many of them never again entered a room with a closed door. No one called it trauma. Because trauma wasn't a word they used for the aftermath of survival. They only measured survival by breath and blood pressure, and if you were breathing, you were healed. But the truth is, they didn't walk out whole, they walked out different. Smaller somehow, quieter, not because the pain was over, but because it had changed them into someone who no longer knew how to scream. Behind every success story was a body that had learned how to freeze, a mind that had taught itself to forget, a soul that had been told, "You're lucky, you're alive, don't ask for more." And they didn't, because to ask for more, for comfort, for dignity, for softness, was to challenge everything the system was built on. Speed, obedience, endurance. We tell stories about the miracle of surgery, about how far we've come, about how medicine eventually found compassion. But the people who suffered before that compassion arrived. They were not experiments. They were not historical footnotes. They were human beings who laid awake tied to tables and endured the blade with nothing but breath and willpower. They didn't receive healing. They paid for it with silence, with terror, with everything they couldn't unsee. And we owe them more than a footnote. We owe them memory.